Imagine you're walking into, like, this massive, brilliantly lit casino.
Okay, I'm picturing it.
Right, so the neon lights are flashing, the carpets have that, that deliberately mesmerizing pattern that's designed to keep you completely disoriented.
Oh yeah, the classic casino sensory overload.
Exactly. And you sit down at this high-stakes blackjack table. Now, you already know the house has an edge, right? I mean, that's just how casinos work.
Sure, it's the cost of entry.
Hmm,
You expect the odds to be slightly against you.
right. But what if you started looking really closely at the rule book sitting on the table, and you realize the house hasn't just stacked the deck?
Wait, what do you mean?
I mean, what if they mathematically and legally rewrote the fundamental rules of probability itself?
That'll be a bold move.
Yeah, so if you happen to win a hand, they simply redefine what the word winning means.
Wow.
And if they lose a hand, they just classify it as a statistical anomaly, void the round, and sweep your chips away anyway.
I mean, it would be a fascinating, albeit completely frustrating ecosystem to observe. It would basically be the ultimate rigged game. A closed, self-sustaining loop where the outcome is controlled entirely by, well, the dealer's control over the vocabulary.
And that is exactly what we are exploring today, because
So-
for you, the listener, we are stepping into a casino that operates on a global scale.
Right?
Only the chips aren't plastic. They are public health policies, massive pharmaceutical interventions, and, billions of taxpayer dollars.
Absolutely.
So, welcome to the Dupe Dive. Our mission today is to explore a really fascinating question. How are safety and efficacy actually established in modern medicine?
And perhaps more importantly, how is that data communicated to you by the global public health apparatus?
Exactly. And we have a massive, incredibly detailed stack of sources to guide us today.
We really do. We're looking directly at official medical literature, government policy documents.
Like the epidemiological reports from the UK Health Security Agency, right?
Right, and the German National Verification Committee. Plus, we're diving into the massive Danish aluminum study, clinical trial data from the Lancet and Nature, and comprehensive Cochrane reviews.
Yeah, these are not fringe documents at all.
Not at all. These are the foundational texts, the industry-approved, settled science that dictates the protocols operating at your local doctor's office right now.
And what makes this deep dive so compelling is, well, how we're going to approach this material.
Yeah, we're taking two distinct perspectives to give you, the listener, the full 360-degree view.
Right. So you are going to walk us through the institutional narrative.
Precisely. I'll be presenting the officially sanctioned, peer-reviewed conclusions that the authors use to assure the public that these interventions are, overwhelmingly safe and effective.
Right. The establishment view.
Exactly. It's crucial to understand what they are claiming and the scientific rationale they provide. I'll outline how these interventions represent some of the greatest achievements of the modern era.
And my role today is to act as the deconstructor. I'm going to look at the raw data buried underneath those headline conclusions.
Leading into the weeds.
Exactly. We're going to explore what the critical voices in our sources describe as narrative engineering. Because when you read the fine print, the actual methodology sections, a completely different picture starts to emerge.
The critical analysis suggests the industry maintains what they call an epistemologically opaque environment.
Yeah, which is quite a phrase. Let's break that down for the listener.
Sure, so epistemology is the study of knowledge, right? How we know what we know.
Right. So an epistemologically opaque environment is basically just a fancy way of saying they've built a system where getting a clear look at reality is structurally blocked.
That's a heavy claim.
It is. The critics in our sources argue that definitive evidence of harm or failure is hidden through, well, sophistry, statistical illusions, and behavioral psychology.
So the data is heavily filtered before it becomes a headline.
Exactly. But it's important to state right at the top, we are going strictly by what is printed in their own data tables.
Right. We are simply comparing their raw numbers against their published conclusions. We aren't bringing in outside theories, and we aren't taking any political sides here.
Impartially reporting the raw mechanics. So, to you listening right now, I want to issue a friendly challenge.
Keep an open mind.
Yeah. Whether you're fiercely pro-mandate, completely anti-mandate, or somewhere in the murky middle, just try to set those notions aside for this conversation.
Just look with us at how the data is filtered and linguistically altered before it reaches your newsfeed.
Let's look at how the house plays its hand. And to understand the rules of this game, we really have to start with the vocabulary.
Right, because if an institution wants to build a bulletproof narrative, They must first control the definitions.
Yeah, the critics call it a vocabulary control system.
The argument is that this system is meticulously designed to ensure the pharmaceutical product is perpetually acquitted of any wrongdoing.
While the natural pathogen is, perpetually convicted, let's ground this in a real-world example from our sources.
Okay, let's look at SSPE, subacute sclerosing panencephalitis.
Yeah, which is a truly terrifying disease. Can you explain to the listener what SSPE actually is, biologically speaking?
Certainly. It's a rare, progressive, and fatal neurological disorder of the central nervous system. It's understood to be a complication of a measles virus infection.
So what actually happens in the brain?
Well, a mutated strain of the measles virus basically lies dormant in the brain tissue, sometimes for years or even a decade after the initial infection.
Wow, a decade.
Yeah. Then, for reasons that aren't entirely understood, it reactivates, causing severe inflammation, progressive brain damage, and ultimately death.
It is absolutely devastating, and the clinical tracking of measles relies really heavily on identifying these SSPE cases, right?
Yes. In the UK Health Security Agency reports we have, they document what they describe as a recent surge of SSPE.
And they track these cases with rigorous detail.
They do. The reports consistently note that the wild-type measles genome has been isolated from the brain tissue of these patients.
Okay, so they find the wild virus.
Right, and they use this finding to reinforce the consensus that the disease is caused by the naturally circulating wild virus. They explicitly note that measles vaccine strains are not associated with SSPE.
But let's look at the fascinating double standard in that exact same UK report.
The discrepancy in the data categorization.
Yeah. The UK document tracked 6 recent cases of this fatal disease. When the researchers look back at the child's medical history to establish when they caught the initial measles infection, how is it classified?
The document labels the initial measles infection as suspected.
Suspected? Why is it only suspected?
Because in 4 of those specific cases, the classification was based entirely on parental recall.
Wait, like a parent just remembering it?
Exactly. A parent simply remembered their child having a high fever and a rash several years prior.
So there was no contemporary laboratory test confirming measles at the time?
No. It relies on human memory, which we know can be highly fallible, especially with childhood viral rashes.
Okay, let's just pause and look at the linguistic gymnastics here. The initial cause, the wild infection they are definitively blaming for the child's death, is officially logged as merely suspected.
Right, based on a flawed memory.
But how is the final SSPE diagnosis labeled?
The SSPE diagnosis itself is labeled as confirmed, typically via the analysis of cerebrospinal fluid.
Do you see the tension there? The tragic end result is strictly confirmed, but the initial cause is just suspected.
Yet they definitively convict the wild virus.
Exactly. Now let's flip the scenario. What happens when a fully vaccinated child develops SSPE?
Because the literature does acknowledge that this mathematically happens.
Right, a child gets the full schedule of vaccines, and yet they still suffer this fatal neurological collapse. How does the institutional literature handle that?
The tone and the vocabulary pivot quite dramatically. The language immediately softens and shifts toward hypothetical explanations.
What kind of explanation?
Well, the authors will often claim the SSPE was triggered by an abnormal immune response in that specific individual.
Oh, blaming the individual's immune system.
Or, more commonly, they hypothesize that the child must have had a subclinical measles infection.
Explain what a subclinical infection means here.
It means the child contracted the wild measles virus, but they never exhibited any noticeable symptoms. No rash, no severe fever.
So it was invisible.
Exactly. The hypothesis relies on the idea that the child was silently infected by the wild virus before or shortly after vaccination, and the parents just overlooked it.
This is a perfect example of what philosophers call an ad hoc auxiliary hypothesis.
Right, a logical escape hatch.
Exactly. When an unvaccinated child dies of SSPE, the paper is titled something like Fatal Measles Complication in the Misinformation Era.
The pathogen is unequivocally guilty.
Yeah, and the parents are vilified. But when a fully vaccinated child dies of the exact same disease, the vocabulary changes entirely. It's suddenly a tragic anomaly.
The critical argument is that the institution introduces an unprovable variable, the invisible subclinical infection, to explain away the failure.
Precisely. They invent a hypothetical, invisible wild virus infection with zero laboratory proof, just to avoid the implication that the vaccine fundamentally failed.
It's a one-way street of attribution. We see this exact linguistic defense mechanism play out in the Gran Canaria Outbreak report, from May 2025.
Oh, the Gran Canaria case study is fascinating. Walk us through the specifics of that.
The report details a situation involving two children, aged 12 and 13 months, enrolled in the exact same daycare center.
Okay, same room, same age.
Both children developed clinical symptoms of measles. Crucially, the onset occurred 6 and 8 days, respectively, after both children had received the measles vaccine.
So a week after the shot, they both break out in measles. What did the lab tests show?
Extensive testing was conducted using PCR analysis.
PCR, the highly sensitive molecular technique, right?
Yes, it amplifies genetic material to identify the exact sequence of a virus. The PCR definitively confirmed the virus in both children was genotype A.
And for the listener, what is the significance of genotype A?
Genotype A is the specific strain used in the measles vaccine. It is distinct from the wild-type strains naturally circulating.
So it was undeniably the vaccine strain replicating in these kids.
Yes, it proves it wasn't a naturally acquired wild infection.
Let's summarize that. Two babies, same room, same vaccine batch, developing the exact same genotype A vaccine strain measles within 2 days of each other.
It looks like either the vaccine directly caused it or one child shed the vaccine virus and infected the other.
Yeah, to any layperson, that's the obvious conclusion. How did the official peer-reviewed conclusion frame this?
The official conclusion stated that the findings highlight the rarity of clinically significant vaccine-associated disease.
Wait, rarity?
Yes, and regarding transmission in the daycare, they concluded it was more likely coincidental rather than a result of transmission.
Coincidental. There is that vocabulary control system doing the heavy lifting again.
Right, labeling a highly specific, localized, genetically confirmed event as a coincidence.
By calling it a coincidence or a temporal association, they place an impossibly high burden of proof on the observer.
Temporal association is a very common pragmatic language tool in public health. It just means two events happened around the same time, but insists one didn't cause the other.
But think about the practical reality for the listener. If you're a parent, how do you mathematically prove to a state-funded agency that it wasn't a coincidence?
You can't. You don't have a multi-million-dollar laboratory to argue your case.
The House defines what a coincidence is, which means the House always wins the argument.
Which raises a foundational question from our sources. If real-world observational failures are written off as coincidences, how do public health agencies prove their interventions are massively successful?
Yeah, where do the massive success headlines actually come from?
Yeah, this brings us to the second major theme, the illusion of efficacy.
Right. The critics argue that when the real-world data doesn't give them the spectacular numbers they need, they simply transition to mathematical modeling.
They create miracles using phantom cases. Let's examine the Lancet study regarding the men-ACWY immunization program in England.
Let's break that down. What's the context for this program?
In August 2015, the UK implemented an emergency adolescent immunization program to combat a national outbreak of meningococcal group W disease.
Which is a very dangerous bacterial infection, right?
Yes, it can cause meningitis and septicemia. Group W is known to be hypervirulent, so the stakes were very high.
What were the headline results published in The Lancet?
The study proudly reports that the program rapidly and successfully controlled the national outbreak, citing an overall vaccine effectiveness of a staggering 94%.
94% effectiveness. That sounds like an absolute triumph.
It does.
But let's look at the raw numbers buried in the data tables.
Yeah.
Out of the entire population, how many actual real-world cases did they physically track as being directly prevented?
According to the data, there were exactly 25 cases directly protected.
Wait, 25 actual human beings?
Yes, 25.
But the headline claim isn't about 25 cases. The authors claim they prevented up to 1,193 cases. Where did the other 1,168 come from?
Those additional cases were generated by a computer model. The researchers designed a mathematical simulation to predict post-vaccination trends based on what they explicitly called an extreme scenario.
An extreme scenario? How did that model function?
The model assumed that without the vaccine, the trajectory of the disease would have continued to rise uninterrupted on a steep upward curve for 4 consecutive years.
They extrapolated the initial spike indefinitely into the future.
Yes, and then credited the vaccine for preventing all of those hypothetical future cases.
But the critical analysis points out a massive flaw there. It violates basic historical epidemiology. Have you ever heard of Farr's law?
Yes, William Farr, the 19th century British epidemiologist.
Right. Farr observed that epidemics naturally follow a bell curve. They don't just rise forever.
They spike, peak and naturally decline.
Exactly. A pathogen runs out of susceptible hosts, or it mutates to become less lethal, and the outbreak burns out on its own.
Farr's law suggests an epidemic is a self-limiting biological event.
But this modern computer model completely ignored Farr's law. It assumed an infinite apocalyptic rise,
Generating over 1,000 phantom cases.
Yeah. Furthermore, what was the actual compliance rate among these older teenagers? Did everyone get the shot?
No. The study evaluates the uptake at a moderate 37 to 41%.
Less than half. So you have a vaccine that didn't reach the majority, a natural epidemic curve likely peaking on its own due to Farr's law, and exactly 25 proven cases.
But the simulation took 100% of the credit for the natural biological decline.
It's astounding. How does the institutional perspective justify this methodology?
The justification relies on the nature of the vaccine itself. MenACWY is a conjugate vaccine.
Can you break down what a conjugate vaccine is?
Certainly. A piece of the bacteria's outer coating is chemically linked or conjugated to a stronger carrier protein. This prompts a robust immune response.
Okay, so it hits the immune system harder.
Yes, and crucially, conjugate vaccines are theorized to reduce nasopharyngeal carriage, meaning they supposedly clear the bacteria from the back of the nose and throat, stopping transmission.
So they use the concept of carriage reduction to justify the massive herd immunity multiplier in their computer model.
Exactly.
But what happens when the institutional data shows a vaccine doesn't stop carriage, or when the predictive data is undeniably poor?
Do they admit the product is weak? According to the sources analyzing the multi-component 4C-MenB vaccine, also known as Bexsero, they employ a very different statistical strategy.
Let's dive into the Bexsero rollout. This targets serogroup B meningococcal disease, right?
Yes. It was introduced into the UK's National Infant Program in September 2015.
Before we look at the vaccine's performance, what was the natural disease burden like before the shot was introduced?
Between the 2007-2008 period and the 2014-2015 period, cases more than halved naturally. They dropped from 11,122 cases down to 440 cases.
A 61% natural drop before the vaccine was ever mandated. The disease was already falling rapidly on its own.
Right. Now, they used a specialized predictive tool called MENLESS to predict if the new vaccine would be effective against circulating strains.
MENLESS, the meningococcal antigen typing system. What is an assay and how does METS work?
Think of it like a highly advanced facial recognition system for the immune system.
Okay, facial recognition.
The vaccine trains the body to recognize certain faces or antigens on the bacteria. The mass assay checks if the circulating wild strains match the faces the vaccine targets.
If there's a match, it predicts coverage. So what did the facial recognition show for Bexsero?
It showed a significant decline in coverage. In 2007-08, MATS predicted 73% coverage. By 2014-15, that had dropped to 66%.
The bacteria were mutating and changing their faces?
Yes. Furthermore, the proportion of bacterial isolates covered by more than one antigen fell drastically from 50% down to 35%.
So the redundancy of the protection was collapsing.
Exactly. And crucially, the authors noted that predicted coverage was lowest in infants.
The exact demographic the government is targeting. So the disease is naturally disappearing, coverage is dropping to 66%, redundancy is collapsing, and it performs worst in babies. Yes. If this were a car seat, it would be recalled. How did the medical establishment spin this data?
When MATS showed poor coverage, they didn't conclude the vaccine was failing. They moved the goalposts.
Oh, of course they did.
They argued the assay itself must be flawed. They claimed MATS provides a conservative estimate and likely underestimates true coverage.
If the test shows the vaccine works, it's flawless science. If it shows it fails, suddenly the test is too conservative. It's a closed loop.
It really is. But wait, it gets more interesting when they discuss the severity of the strains.
What did they say about the 66% of strains it actually did cover?
The researchers noted that MATS-positive strains, the ones successfully covered, were associated with much more severe disease outcomes, including intensive care admission and death.
Okay, how on earth did they interpret that grim finding?
They stated in their discussion, the association we identified between MATS-positive strains and increased severity of disease, although expected, is reassuring because it suggests that immunized infants might develop milder disease.
Reassuring. They actually use the word reassuring.
Yes, they did.
Let's unpack the sophistry here. The vaccine fails to protect infants against 34% of the circulating strains. If a baby catches a negative strain, zero protection.
Correct.
Instead of admitting the product leaves infants completely vulnerable to a third of the pathogens, they spin the fact that it only targets the deadly ones as reassuring.
framing a massive gap in coverage as a feature, not a bug.
It's just wild. Which brings us to another foundational statistical concept, the distinction between relative risk and absolute risk.
Right, a common statistical tool used to communicate massive efficacy to the public. We see this vividly in the Cochrane review for the RSV vaccines.
The RSV Cochrane review is a masterclass in statistical framing. What were the headline claims?
RSV is a common respiratory virus, potentially dangerous for infants and older adults. The Cochrane review highlights a 77% efficacy for older adults.
And for maternal vaccination during pregnancy.
A 74% reduction in severe RSV-related illness in infants.
77% and 74%. If you read that in a waiting room, your reaction is, I'd be crazy not to get this. It stops 3/4 of the disease.
But the critics argue this is a mathematical illusion based on relative risk.
Right. Can you explain the difference for the listener? Let's use the lottery analogy.
Sure. Say your baseline chance of winning the lottery is 1 in a million. That's your absolute risk, the raw mathematical probability.
Okay, 1 in a million.
If you buy a second ticket, you've doubled your chances. Your relative risk increased by 100%.
A 100% increase sounds massive.
But your absolute risk only shifted from 1 in a million to 2 in a million. It's still practically negligible.
So how does that apply to the RSV vaccine data? Let's pull the raw numbers. Out of 1,000 pregnant women, what was the real-world risk of the infant getting severe RSV if the mother took the placebo?
The data tables show the risk with the placebo was 1.4%.
1.4%. So 14 babies out of 1,000. What was the risk if the mother took the vaccine?
The risk dropped to 0.4%.
Okay, from 1.4% down to 0.4%. The absolute risk reduction is exactly 1.0%. The vaccine prevented 10 cases out of 1,000.
But by dividing that tiny 1.0% drop by the initial 1.4% baseline, you mathematically arrive at a 74% relative risk reduction.
And they broadcast the 74% everywhere. They manufacture a perception of massive, urgent necessity.
A 1% absolute reduction might not convince a mother, but a 74% relative reduction absolutely will.
But let's look at the clinical outcomes that actually matter. Did these massive trials prove the vaccine kept babies out of the ICU or stopped them from dying?
This is a critical point. The Cochrane review explicitly states that across trials involving 12,010 people, they, quote, did not report ICU admission.
They ran trials on 12,000 people and literally didn't report ICU admissions.
Correct. And regarding mortality, the review notes there may be little to no difference in infants who die from RSV or all-cause mortality. The data simply did not show a life-saving benefit.
And how did the authors categorize that failure?
They assign low-certainty evidence to the failure to demonstrate a reduction in mortality.
Low certainty evidence. When it reduces mild symptoms, it's high certainty 77% efficacy. But when it completely fails to prevent death, they just call it low certainty evidence.
It rhetorically implies, oh, it probably saves lives, we just need more data.
It perfectly shields the product from the objective reality of the trial's limitations.
So if efficacy is routinely amplified through models and relative risk, how is safety managed? How are severe adverse events, or SAEs, handled so they don't derail public confidence?
The argument is that harms are statistically laundered. Let's look at how safety is established in those RSV trials.
The Cochrane review concludes there may be little to no difference in SAEs between the vaccinated group and the placebo group.
Little to no difference. Now, listeners probably assume a placebo is an inert substance, like a syringe of simple saline.
Harmless salt water.
Right. So if the vaccine group gets sick and the saline group is fine, you have a clear safety signal. With the placebo just salt water?
In major studies, such as the Walsh 2023 trial, the methodology notes they utilized a placebo that was lyophilized to match the appearance of the vaccine.
Lyophilized. What is an active placebo?
Lyophilization is a freeze-drying process. With an active placebo, they give the control group all the same chemical excipients, adjuvants, stabilizers, and buffer solutions present in the actual vaccine.
Everything except the specific viral antigen.
Exactly. The control group still gets a complex chemical cocktail.
Why do researchers argue this is necessary?
To maintain the double blind. If the active vaccine causes a red, swollen arm and saline doesn't, both doctor and patient know who got the real drug.
So they make the placebo reactive to preserve the blind.
That's the institutional defense.
But the critical counterargument is huge here. If those chemical buffers and adjuvants in the placebo are highly reactive and cause severe inflammation, what happens to the data?
Both groups will likely experience a very similar rate of adverse reactions.
Exactly. Because they both suffer at the same rate, the researchers compare the spreadsheets, see no statistical difference, and declare There is no difference in SAEs.
The critics argued this effectively uses the toxicity of the active placebo to mathematically mask the baseline harm of the ingredients.
It's a statistical sleight of hand. And this concept of masking the true baseline is most aggressively demonstrated in the Danish aluminum study.
Yes, the Statin Serum Institute study. It's frequently cited as definitive proof that aluminum adjuvants are safe.
The smoking gun of false comparators, what was the scale of this study?
It tracked over 1.2 million children in Denmark.
And what are aluminum adjuvants, just for context?
Substances added to vaccines to provoke a stronger immune response. Concerns have been raised about cumulative exposure linking to autoimmune or allergic conditions like severe eczema.
And what did the massive study conclude?
It definitively stated there is no association and no evidence supporting an increased risk of these diseases related to aluminum exposure.
A 1.2 million kids study claiming no evidence of risk sounds completely unassailable. But did they have access to completely unvaccinated children to use as a control group?
Yes. The dataset explicitly included 15,237 completely unvaccinated children, zero aluminum exposure.
A pristine biological baseline. Did they compare the vaccinated kids against the unvaccinated kids?
According to their methodology, no. They deliberately refused to use the zero exposure group as the baseline reference in their primary model.
If they didn't use the unvaxxed kids, what mathematical model did they use?
A continuous variable model, analyzing the data per 1 milligram increase in aluminum.
Meaning they compared vaccinated kids to other vaccinated kids.
Yes, looking for a trend line between kids with slightly lower doses versus slightly higher doses.
They took the only true unpolluted baseline in the entire country, 15,000 kids, and just erased them from the statistical model. Why would they do that?
Well, independent researchers gained access to the raw case counts and ran the crude numbers themselves, comparing vaccinated to unvaccinated.
And what did the unadjusted raw data show?
The completely unvaccinated children showed a massively reduced risk of allergic disease.
Wow.
Highly significant crude incidence rate ratios of 0.73 for atopic dermatitis and 0.66 for allergic rhinoconjunctivitis compared to the vaccinated cohort.
The unvaccinated kids were significantly healthier. The objective raw data violently contradicted the institutional narrative.
So the authors utilized the continuous variable model to mathematically swallow and hide the unvaccinated baseline.
And who actually authored this massive study?
Researchers at the Statin Serum Institute, which is a state-owned enterprise in Denmark that physically produces and profits from the sale of vaccines.
A state-owned vaccine manufacturer investigates its own product, deletes the healthy control group, runs a model comparing toxicity against itself, and publishes no evidence of risk.
It's a prime example of an epistemologically opaque environment.
It's breathtaking. And the literature is equally capable of doing the exact opposite. They erase healthy unvaxxed baselines, but they actively curate hyper-healthy vaccinated baselines.
You're referring to the recent COVID-19 literature, the Nature Communications paper.
Yes. How did they engineer a flawless safety profile by manipulating the baseline in that paper?
The paper examined the incidence of severe cardiovascular events, like heart attacks and strokes, after COVID-19 vaccination.
And what did the abstract conclude?
It broadly concluded that the incidence of these events was generally lower after vaccination, providing compelling evidence of a net cardiovascular benefit.
They claimed an inflammatory injection miraculously lowered the rate of heart attacks. But did they admit to any methodological bias deep in the text?
Yes, deep in the discussion section. They acknowledged they did not adjust for potential confounding by factors that may have influenced receipt of vaccination.
Like what?
Like development of respiratory symptoms or being admitted into a hospital leading to postponement of vaccination.
Let me translate that. If a person was in the hospital dying of cancer or having chest pains on a Tuesday, they obviously canceled their vaccine appointment.
Naturally.
Therefore, the only people who actually walked into a clinic to get the shot on any given day were, by biological definition, the healthiest people in the entire cohort.
Epidemiologically, this is known as the healthy vaccine bias. The act of receiving the intervention selects for individuals already in good health.
And they completely failed to adjust for it. They just watched these ultra-healthy people predictably not have heart attacks for a few weeks, and then gave the product 100% of the credit.
And how long did they track these patients before declaring it safe for wide uptake?
Oh, this is the best part.
They censored all analyses 26 weeks after vaccination.
At 26-week blindfold, they stopped looking after exactly 6 months.
And acknowledged they didn't address long-term safety.
If an independent researcher used this exact methodology to prove a natural supplement was safe, they would be laughed out of the scientific community.
It highlights the systemic asymmetry. The evidentiary standard to prove safety is incredibly flexible, but the standard to prove harm requires absolute genetic proof while still being dismissed as coincidental.
Which brings us to a baffling contradiction. If the clinical data is this heavily engineered, why is the public constantly told that their unvaccinated neighbor is an existential biological threat?
Let's transition to the myth of the static herd. Herd immunity is the cornerstone of public health policy.
Can you define it clearly for the listener?
It posits that if a high enough percentage of a population is vaccinated, the virus can't find a susceptible host. Transmission stops, protecting the vulnerable minority.
Mathematically beautiful. But traditional epidemiology requires closed systems.
Right, and we live in a highly fluid, massively globalized society.
With entirely porous borders and constant travel. Applying a static algebraic formula to modern society is biologically impossible. But let's look at the ultimate historical triumph of herd immunity. Polio.
Polio is universally cited as the absolute gold standard of mass vaccination success. The incidence of wild poliovirus has decreased by over 99% since 1988.
Wild poliovirus. Let's focus on that word. Explain the difference between the polio vaccines used globally.
In developed nations, the inactivated polio vaccine, or IPV, is used. It's a dead virus. But in developing nations, they heavily use the oral polio vaccine, or OPV, which is a live attenuated virus.
And the OPV creates mucosal immunity in the gut, right?
Yes, and is then excreted by the vaccinated individual into the environment.
It's excreted. What happens when a live, genetically modified virus is introduced into an environment with open sewage?
It circulates through the water and soil.
Yes.
As it passes through multiple human hosts, it can genetically mutate and revert to neurovirulence.
Meaning it regains the ability to paralyze people.
Yes. This is known as circulating vaccine-derived poliovirus, or CVD-PV.
And what do the epidemiological numbers look like today regarding this vaccine-derived strain?
According to recent data from 2024 and 2025, cases of vaccine-derived polio have consistently outnumbered wild polio cases by a factor of roughly 5 to 1 globally.
5 to 1.
Furthermore, genetic sequencing shows this vaccine-derived strain is currently circulating in the wastewater of fully industrialized cities, including London and New York.
The cure is actively paralyzing 5 times as many children as the wild disease. We swapped a natural pathogen for a pharmaceutical one that's now shedding into the sewers of London.
And the institutional solution to these vaccine-seeded outbreaks.
Please tell me it's not more vaccines.
Global health bodies deploy a novel oral polio vaccine, NOPV2, to stop the spread.
They dump more live, modified viruses into the environment to fight the virus that mutated from their last vaccine. It is a perfectly closed business model.
Calling it eradicated is arguably a PR marketing slogan. This touches on a broader debate about ecological baselines.
The institutional narrative claims vaccines were the sole heroic savior against infectious diseases, right? The iron lung theatricals.
They project mid-century horror onto the present day. But the critics argue this completely ignores how human beings actually survived.
Let's talk about the Leicester method.
In the late 19th century, while many regions strictly enforced smallpox vaccination mandates with heavy fines, the town of Leicester actively rebelled.
Did they just let the disease ravage the town?
No, they implemented a highly organized system focused entirely on sanitation and containment. Rapid isolation, strict quarantine, and massive investments in clean water and hygiene infrastructure.
And what were the epidemiological results?
Their mortality rates plummeted, remaining far below the rates of heavily vaccinated regions that lacked similar sanitation.
Mortality rates for these diseases crashed by massive margins, up to 98% before the vaccines were ever introduced.
Better nutrition, clean water, indoor plumbing, and refrigeration did the heavy lifting.
The pharmaceutical industry just branded nature's work and sold it back as a mandatory product.
Yet, institutional messaging warns that local pockets of vaccine hesitancy are the primary driver of modern outbreaks.
Let's critically examine that claim. The 2024 German National Verification Committee report on measles, a highly publicized outbreak with 645 cases.
And what was the mortality rate?
0. 0 deaths. But here is the smoking gun. Where did these cases originate?
The report explicitly admitted that 83% of those cases were imported or import-related,
They openly documented the virus spreading through massively overcrowded asylum facilities.
noting it was not possible to strictly isolate each case due to the size of the facility.
The government deliberately oversees a system with highly porous borders, imports hundreds of thousands of people, packs them into failing infrastructure, and obviously a respiratory virus spreads.
Yet public communication rarely focuses on infrastructure or border policy.
Because it's infinitely cheaper for the state to deploy a PR campaign blaming a domestic parent for vaccine hesitancy. They mathematically guilt-trip the domestic population while their own asylum centers generate the problem.
They erase the structural reality to protect the political narrative. Which brings us to the final section. If the data is this debated, how does an institution get millions to comply?
They stop teaching biology and start utilizing weaponized behavioral psychology.
Governments employ dedicated nudge units, like behavioral insights teams, utilizing frameworks like the COMB behavior change wheel.
What's the stated goal of these nudge units?
To combat the infodemic and correct the public's lack of health literacy to ensure compliance.
Correct their lack of literacy. It's incredibly patronizing. How does the COMB model work?
COMB stands for Capability, Opportunity, Motivation, and Behavior. It identifies why a person isn't complying and designs nudges to change it.
Let's apply this. Say a parent reads the methodology of the Danish aluminum study and asks their doctor a mathematically sound question about deleting the control group.
Within the CMMB framework, questioning the established science is often reframed as a capability deficit.
A capability deficit.
Yes. Diagnosing the citizen as lacking the intellectual capability to understand complex science, requiring highly simplified emotional messaging to correct them.
They diagnose your ability to read their raw data as a psychological defect. They reduce complex immunology to retail slogans like a simple step to safeguard your health.
It's an intentional reduction of complexity. The policy pushes for co-administration of seasonal vaccinations and champions, making every contact count.
What does that mean clinically?
Medical staff are trained to opportunistically push vaccinations whenever a patient presents, even for an unrelated issue like a sprained ankle.
Treating the complex human host like a sterile petri dish on an assembly line, they completely ignore individual baselines. And the critics point out the absolute erasure of seroconversion.
Seroconversion is the actual physiological process where the body develops detectable antibodies. It's objective biological proof the vaccine worked.
Does the state ever test for it? Do they follow up 3 months later to check your blood titers?
No, routine titer testing is not standard practice. Uniform protection is simply assumed across the board.
Blindly assuming 100% efficacy across a wildly diverse population. They ignore if a child was born via C-section, their gut microbiome, their vitamin D levels.
If you point out secondary vaccine failure is rampant, COMB labels you a behavioral threat.
And this reliance on behavioral management is driven by weaponizing fear, elevating perceived severity.
They use dramatic imagery to generate panic. This creates a rhetorical structure akin to the Motte-and-Bailey fallacy.
The Motte-and-Bailey is the perfect analogy here. Explain it for our listeners.
In medieval times, the motte was a heavily fortified stone keep on a hill, safe but small. The bailey was the expansive, productive land below, but very vulnerable.
Okay, so in an argument.
The motte is a basic, undeniable truth. The bailey is a highly controversial claim. When challenged on the bailey, the arguer retreats to the motte and accuses the opponent of attacking the undeniable truth.
So what is the motte in public health?
The undeniable biological fact that wild infectious diseases can cause severe harm or death in vulnerable populations.
And what is the bailey?
The expansive claim that because the disease is dangerous, the pharmaceutical intervention must be flawlessly safe, universally effective for everyone, and legally mandated.
Boom. So when you point out the Bexsero vaccine failed its assay, you're attacking the bailey.
But the state PR machine retreats to the motte. They say, do you want babies to die of meningitis? Look at these horrific photos.
They leverage emotional fear to completely shut down scientific inquiry into the product's failure.
It flattens nuanced debate into an artificially simple binary: unquestioning compliance or sociopathic endangerment of children.
It's a massive psychological operation funded by your own tax dollars.
So, synthesizing all this, what overarching picture emerges?
It brings us right back to the casino. The vocabulary control system confirming wild virus but dismissing vaccine injury, active placebos masking toxic baselines, phantom computer models, behavioral nudge units.
An epistemologically opaque fortress.
A closed loop where the industry simply cannot lose.
I want to leave the listener with a final historical note. In 1989, Dr. Milson observed a clear case of measles transmission from the live attenuated MMR vaccine between siblings.
He documented it and wrote to The Lancet. And what happened?
He was immediately and publicly dismissed by the chairman-elect of the UK's Joint Committee on Vaccination and Immunisation, who declared there was no possibility of such transmission.
The observation was erased.
Today, under the WHO's revised causality assessment protocols, all new serious adverse reactions are almost automatically categorized as coincidental or unclassifiable.
The causal association is structurally not acknowledged. So we leave you with this final thought.
Right.
If the burden of proof is continuously placed on you, the individual observer, if you're expected to produce billion-dollar forensic resources to prove a negative against a state-funded PR machine that controls the very definitions of the words being used.
At what point does settled science stop being an objective pursuit of truth?
And at what point do you realize you're just sitting at a rigged blackjack table playing against a dealer who rewrites the rules every time you draw a card?
It is certainly a question worth asking.
Thanks for diving deep with us today. Keep your eyes open, keep asking questions, and we'll see you next time.